Hi, everyone. Welcome back to the Breast Cancer Podcast. Hello, I'm your host, Dr. Deepa Halaharvi, a fellowship trained breast surgeon, and also happen to be a breast cancer survivor, thriver, and a warrior, living my best life. As you know, breast cancer affects millions worldwide, touching lives in a profound ways. Whether you're someone facing a diagnosis, or a supporter seeking information, or just eager to learn more, this podcast aims to be a beacon of understanding, hope, and empowerment. I'm here to talk about all things breast cancer, from surgery to survivorship, as well as high risk for breast cancer to metastatic breast cancer. My goal is to provide you with reliable information, share inspiring narratives, and foster a supportive community. I know firsthand the challenges breast cancer diagnosis brings. Throughout this podcast, I will give you strategies to handle difficulties that arise from cancer diagnosis. We'll have insightful conversations with medical experts, researchers, survivors, caregivers, and advocates. I will tackle topics that impact our lives as cancer survivors. My goal is to educate you and empower you to live your best life. I definitely have. Well, let's get started.
So, what's on the agenda today? We have education by our wonderful experts who are going to give us evidence based education on how to care for yourself after breast cancer. You're going to be empowered by asking questions in the speed dating session, where you're going to be writing down your questions on the note cards and pass it to our beautiful volunteers right there. You want to hold your hand up and they'll come and pick up the note card. And last but not least, the fashion show. You will not want to miss it. There's beautiful music. There may be some fog. There's a lot of tissues. It's going to be beautiful. So don't leave. So we start with advances in after breast cancer care. That's our first session. As we start this evening, this is one of the least discussed topics with the survivors. When treatment is over, you really don't know, should you be getting scans, should you not be getting scans? Do your doctors talk about it, do they not? What happens after treatments? Because really, survivorship starts when the treatment ends. So I'm really excited to welcome one of my most favorite human beings on this planet. When he's not saving lives, he's fishing, running marathons and Ironmans. Please welcome amazing speaker and the moderator, Dr. Mark Cripe. Give it up for me.
Thank you. I thought you were going to talk about your husband. Sorry. All right, great. Thank you for our sponsors. This is a great event. Thank you, Dr. Al-Harbi, Dr. Dewani. It's going to be amazing. A couple things again, as she mentioned, housekeeping. Fill out your pre-test questionnaire. So we're trying to get a study out of this. We're going to know what you guys know now. So if I start talking and then you fill it out, you cheated. So fill out your pre-test questionnaires. And then we're going to also take questions from the audience. So if you guys have questions, we're not going to pass it on the mic. That will take too long. You have little note cards and a pen. And so then write your questions down. We'll pass them around. And I get to choose what they ask the audience. Or that's our experts. So make sure I can read them too. The last thing, this will be recorded, and it's going to be available soon on the Breast Cancer Podcast and also on YouTube. So Dr. Halaharvi wanted me to mention that. So we're going to be talking now about my topic, which is to scan or not to scan. That's the question. And a lot of people have this question as you go through your treatment, and maybe you're getting chemotherapy and you're seeing people weekly, you're getting radiation, you see people daily, and then all of a sudden, it's done. It's over. Okay, what next? How do I know I'm cured? How do I know is my cancer gone? What do we do? So we're going to go through some recommendations. So screening of the breast, and what do we do for that? Well, what about if the cancer's traveled? How do we check the rest of the body? And then lastly, future and what's coming down the road here. So how do we decide what we're going to do? Is it like, am I in a screening day today or not? Like, how do I decide what tests we're going to get for everybody? We actually have national guidelines. So just to start with, we don't just take it off on a whim on what we're going to do and how we're going to screen people, but we have to follow national guidelines, so we use the National Comprehensive Cancer Network. So when you go into survivorship, here you go. So, all right, for your post-test, memorize this. This is going to be on your post-test, all right? I'm just kidding, that was a joke. So I'm going to talk about imaging of the breast. So just 3 things. So imaging of the breast, what are we supposed to do? Again, national guidelines, these aren't things that we make up. If you have a lumpectomy, we still get a mammogram once a year. We used to do it twice a year, and it doesn't really help, and it costs more money and causes more anxiety. So nationally, a number of studies once a year, and we typically start it about 6 months after radiation's ended, sometimes a little bit sooner, and it just kind of depends. We have to get some of that radiation changes gone before we image the breast. When you have reconstruction, so either if you have a mastectomy and you have flat closure, or you have an implant, or you're using some of your belly tissue, like belly fat, like we're going to talk about later, no imaging for screening of the reconstructed breast. So a lot of people come in and say, okay, I've got an implant, how do I know if something's hiding behind it? Am I going to get an MRI? What am I going to get? No recommendations, or recommendation for no screening and just physical exam. We'll kind of keep going into that a little bit. I also want a little asterisk, if you have a genetic mutation, we're going to do screening of other organs. We're going to get into that as far as the ovaries, pancreas. Hopefully none of you ladies have a prostate. If we do, I'm not sure, but no imaging of the prostate. But again, those are for other cancers and genetic mutations for us guys. So when we're talking about screening the breast, what about then if cancer is spread somewhere? What are we going to do? A lot of people know that your neighbor had a PET scan because they had lymphoma. Your neighbor's friend had colon cancer, they get CAT scans, they get tumor markers, and then your neighbor's friend's dog had another thing, and they get that. It's not all the same. So just knowing that from a breast cancer standpoint, screening recommendations for the whole body, where do we go? We go back to our NCCN guidelines, and what do we do? Without signs and symptoms of any recurrence, we don't do any imaging. So that's a hard thing to swallow. A lot of people, again, used to get mammograms enough. You had a mastectomy, you don't get any imaging, and it's like you kind of want something to prove it's all gone. Nothing really works, and that's the tough thing. So we don't do imaging for breast cancer surveillance for distant, if it's been kind of a localized disease. So that means no labs, no more imaging, CAT scans, PET scans, no tumor markers. Tough thing. If you have signs or symptoms, then we're going to look further. So what's a sign or symptom mean? So I look at it, one way is like a local or regional disease. So if you have a mass, so either in the breast, or if you've had reconstruction in the reconstructed breast, if you have a lymph node, so lymph nodes can be kind of an olive, either in the armpit or above the collarbone, nipple discharge, nipple inversion, or if you start to see something pulling out on the skin and you get this retraction, those are things that we're looking for, and we're going to do more screening. From a distant disease, so again, that's what everybody wants to know about. There's 4 places breast cancers like to go. 2 start with an L, so lung, liver. 2 start with a B, bone, brain. So if it goes to the lungs, you're going to notice a cough, there's fluid there. It goes to the liver, jaundice or abdominal pain. Bone pain, we get this a lot, like, you know what, I was working out really hard, my bone hurts back here. That's not what we're looking for. It's a pinpoint, kind of always there, bony pain. That's the things that we're looking for. Or brain. Worst headache of your life. Again, if you have migraines and you have your migraine, that's not what we're looking for. It's the worst headache of your life, or visual changes. What about the future? So all that's kind of hard to swallow. Again, you've been doing all this imaging, doing all these things, then it stops, we're not doing anything. Where are we looking to the future? I really think it's going to be circulating tumor cells. That's something that's out now. We're starting to do it a little bit. It's still not prime time. There's some issues with it. But basically, it's doing a blood test, taking some blood, and seeing if there's any tumor cells in it. That would be great if it worked all the time. It doesn't work all the time. We've used it in a few patients, I think maybe 5, 10 years, maybe 20 years down the road. That's something we're going to be doing a little bit more. So stay tuned. Have some issues with it again, but if you want to look to the future, that's where we're going. I think that's my 5 minutes. So thank you all. We're going to continue. Again, write down questions if you have them on note cards, pass them to the volunteers as we continue to go along. Next, we're going to talk about optimizing outcomes after reconstruction, the latest advances in 2025. Dr. Nirvana Saraswat did his residency here in Columbus, Ohio. He went up north for a fellowship, I think, to the University of Michigan. Interesting fact about Nirvana, he grew up right here in Dublin, Ohio, and just had his first child 8 weeks ago. So, Dr. Saraswat, welcome.
All right, so I didn't go to the University of Michigan. I probably would have passed if that was the case, but I was up for Cornwall Health, and I'm really glad to be back home. So first off, I'd like to thank Deepa, Shabana, Mark, all of our sponsors, and of course all of our patients, survivors, and healthcare providers who are here today. Thanks for having me talk, and I'm excited to talk about some of the latest advances in breast reconstruction. So I don't want to bore anyone with a history lesson, but I think it is important to kind of look back and see where we've come. Dr. Czerny famously in the 1800s put a lipoma in a patient's breast after removing a tumor. And I don't know how good that was aesthetically, but the thought process was great. And, over the following decades and into the 1900s, that idea of reconstruction continued to develop. Local tissue transfer and muscle flaps kind of gave way to the development of breast implants, which really kind of changed the game as far as breast reconstruction in the 1950s. And then, as the 1900s went on, those flat-based procedures became more advanced, more nuanced, targeted for each specific patient, and the pedicle flaps gave way to, in the 1980s, free flaps, which really added another dimension to the game. This century, there was a shift more towards those perforator flaps, so sparing muscle. There were also advances in mastectomy techniques as well. In the 2010s, we really had a big focus on patient-centered outcomes, what kind of reconstruction affects patients in different ways, and the increasing use of fat grafting and hybrid reconstructions, again, just added more layers, more options. And in the 2010s as well, the fifth generation, I should say generation, implants were approved by the FDA. So throughout that whole time, from the 1950s, we've been continuously improving the implants that are made, in addition to the flat-based and tissue-based techniques. So, and then finally in the 2020s up until now, advances in neurotization, robotic-assisted flap harvest, 3D imaging and perfusion mapping are really kind of the cutting edge and what we're using, especially for tissue-based reconstruction. So specifically with tissue-based reconstruction, some of the advances and some of the things that we're utilizing as much as possible these days are hybrid reconstruction. So initially using the flap, but then if more or less tissue is needed, especially with volume, adding fat transfer, adding implants at a secondary stage, something we could operate in a hybrid setting. Stacked or bipedical flaps, especially for unilateral reconstruction, are possible. And we're always trying to decrease the donor sites and decrease exposure, because reconstruction is great, but we really want to minimize all those secondary effects of using your own tissue. The D-flap nowadays is kind of the workhorse, but a variety of other workhorses have emerged, and we've gotten better at using them. These include the lumbar perforator flap, profund artery perforator flaps, the transverse gracilis flap, and the gluteal artery flap. In addition, we routinely get CT angiograms on all of our patients for preoperative planning. We've gotten better with the protocols for CT angiograms, so minimizing radiation, minimizing contrast, and really targeting what we need to see. And with the radiographs that we get at the hospital, 3D reconstructions have been done for probably decades, but there is newer software that kind of takes all of the raw data from these CT angiograms and kind of creates a much more detailed, interactive form of mapping that is pretty helpful. It's not absolutely necessary for every case, but it really, with these 3D models, you can kind of rotate the tissue, get an idea of where you want to be, and adds another level to planning. So robotics and breast reconstruction. So robotic surgery has kind of found a foothold in many, if not all, surgical specialties, and plastic surgery is really no exception. The robotic team has been pioneered in the last 10 to 15 years. It's growing and gaining some traction among patients. So for the right patient who has the right perforator anatomy, it's a great way to minimize fascial incisions, to have improved muscle recovery, and really superior ergonomics for surgeons who, do the surgery day in and day out. And the next level of robotics in surgery and robotics in plastic surgery is one of the models is the Sbrocchi robot, which is a super microsurgery robot. And as opposed to kind of the macro movements of a Da Vinci, this has micro movements and allows for procedures mostly kind of lymphedema oriented with minimal movement error, and it allows for really kind of the next level of reconstruction. So the picture on the right in the bottom kind of shows the scale of the arms that are used for this type of surgery with the needles in comparison to human hair, which I'm not sure why human hair is on the surgical field, but so really small. And then resensation and neurotization is taken off. There's a growing body of evidence on the benefits of attaching nerve ends between the chest and the flap. This can be done in a variety of ways. There's direct repair using conduits or using nerve grafts. But what we're seeing is, it may improve the quality of life for patients. And some possible benefits include increasing sensibility beyond just protective sensation, improved proprioception, and awareness of the body. And then, enhanced recovery after surgery is something we're always talking about. Traditionally, patients who had pre-flap or breast reconstruction were in the hospital for a long time. We kept them in the hospital for a week or more on bed rest for 5 or more days. And as time went on, we realized that getting them up out of bed sooner, kind of getting them back on their feet, so to speak, allowed them to feel better sooner and kind of get back on the path to recovery much quicker. So we have borrowed a lot of the ERS protocols from general surgery and modified them to fit a plastic surgery setting, but preparing for surgery really begins before the patient's ever in the operating room. And so we talk a lot about rehabilitation regimens to optimize your health, hydration, protein intake, really get you ready for the stress of surgery. Intraoperatively and directly postoperatively, we always talk about multimodal pain medication, attacking the pain from multiple different directions with anti-inflammatories, opioid pain medication, and blocks as well. And then postoperatively, again, starting food earlier, moving, getting out of bed, post-operative one, getting out of the hospital in a day or two, as well as decreasing lines, strains, all the things that hold you back from getting back again on your feet and back on the path to recovery. Well, that's all I have. This is a recurring set of numbers, but the reason for most of the
Next, we're going to change to medical oncology. We're going to have Dr. Shabana Dewani. The next chapter, Thriving, Not Just Surviving After Breast Cancer. She's one of our medical oncologists here at Ohio Health. She sees many of our breast cancer patients. An interesting fact about Shabana is that she loves Bollywood music and dance. She performed and competed until entering medical school. Maybe we can get a little example later.
Thank you, Mark. All right, so when do we think survivorship really starts? Is it end of treatment? Probably not. It actually starts with your diagnosis. The time your diagnosis is made, that's when your survivorship starts. We as medical professionals, we start planning your treatment to see what's going to be most effective and least toxic so you can live your life afterwards as close to normal. Well, why is survivorship important? So if you look at some statistics, back in 2019, we had about 3.4 million breast cancer survivors, and by 2030, we will be close to 5 million breast cancer survivors. So it is right now, like if I look at the room, why are you all here today? There is that unmet need, there is that thirst, there are some questions that are unanswered, and that's why you all are here, seeking for some answers, like what is more out there? What can I do more to make sure that I am living my life to the fullest? Is there something out there that I'm not missing? And So let's talk about not just surviving, but also thriving. So how do you define thriving? So thriving is based on 3 pillars: knowledge, strength, and gratitude. To every survivor in this room, you are not defined by what happened to you. You're defined by what you choose to rise into. Thriving is living boldly, joyfully, and unapologetically. Well, the big question is how, right? How do I overcome the barriers? How do I reclaim my strength and my energy? How do I find the purpose and joy again? And there are so many looming questions on your mind. Well, we split it in 3 parts: physical, mental, and financial, right? So body, mind, and financial health. Financial health is, we as physicians usually don't talk about, but it's such an important part of our patient's life, and I think it's such an important part of our survivors too. So talking about body, when we give you treatments, especially, I always tell my patients when they complain of this bad hot flashes, I am like, I'm getting close to menopause, and I'm like, my karma is gonna come back to me real bad. So hot flashes, joint aches and pains, neuropathy, vaginal dryness, weight gain, insomnia. And then mentally, like more depression, anxiety, cognitive difficulties, body image, and survivor guilt. It's very interesting when like people will tell survivors, you look great, everything feels good, but in the mind of the survivor, they're like, I don't feel exactly how I felt before everything happened. So sometimes there is a disconnect between you and the real world, and that can be sometimes frustrating. And the interesting part is mind and body are connected, right? So if you don't sleep properly, you will feel fatigued next day. If you have anxiety, you won't sleep properly. So both mind and body are very interconnected. And then we talk about the financial burden. So there was an interesting statistics where 42% patients of breast cancers during their survivorship, a survey was done which mentioned that about 70% of them chose not to take any leisure trips or do anything fun because that was a financial burden on them. So many of them did not fill their prescription. They're like, okay, do I need to pay my mortgage or pay for my medications? Some of them just partially filled their prescription. So that is a big, big financial toxicity that we have to touch while we are talking about survivorship. All right, so I'm gonna give some key points about things that survivors face. So hot flashes. So me giving you medications, putting you in menopause causes hot flashes. And medications, anti-estrogen treatment, aromatase inhibitors, and chemo can cause menopause. So usually, we try to start with something that is non-hormonal like vitamin E, magnesium supplements, but then if that's not effective, we try to go to something that's more prescription. We try to pick a medication based on what your other symptoms are. If somebody has neuropathy, from their treatment, then we like to use gabapentin as it will work for both. If somebody has anxiety and depression, we like to use something like Effexor, which will help with both. One of my personal favorite is oxybutynin. It's actually a drug that was approved for overactive bladder, but works wonderfully for hot flashes. I don't know if there are anybody who's using it. And then there is and there was actually a trial that used oxybutynin, and it showed significant good results in terms of control of hot flashes. And a lot of you have heard about Veoza. That's the new drug on the market that helps with the hot flashes. And then there are non-drug approaches like acupuncture, exercise, mindfulness. So there was a study that looked at people who did acupuncture. About 64% of them experienced less hot flashes compared to 18%. Vaginal dryness, something we usually not frequently talk about. We always encourage our physicians to bring this conversation up because not many people are forthcoming and talking about this topic. Apart from like non-hormonal first-line treatments like moisturizer, lubricants, there are hormonal options that we use. We are actually opening up more and more, becoming more acceptable of using low-dose vaginal estrogen. There was actually a very nice presentation done in December in San Antonio Breast Conference where they talked about that did not significantly impact or increase the risk of breast cancer. Again, this may be different for every individual. So if you're experiencing it, please discuss with your provider. This might be an option for you. Because this is not something you take for 3 months, 4 months. You're talking about this medication 5 years, 10 years. So you have to have something that makes life better. All right, and then joint pain and stiffness. Typically, estrogen is responsible for, I'm getting my signal, sorry. Joint pain is basically, estrogen is important in terms of maintaining the elasticity of your tendons, helps with the collagen, and as you take that away with decreasing the estrogen, you start feeling stiff in the morning and you experience joint aches and pains. One of the common things people fear about that is this causing some permanent damage. It actually is not, it's just decreases the elasticity and decreases the collagen. We try to switch, give them a treatment break from their medications, try and switch to a different aromatase inhibitor or medications, use medications like duloxetine, sometimes ibuprofen to help with the relief. There is on Facebook University and blogs, a lot of patients attest to Claritin to use for joint aches and pains. Studies have shown acupuncture and exercise are the two big things that actually helps joint pain that is induced by aromatase inhibitor or tamoxifen. This is the big thing because higher the BMI, higher is the risk of recurrence because your fat cells store estrogen, so we want to make sure that lower the BMI decreases the risk. So healthy eating, lots of fruits and vegetables, less processed meat, less red meat, or no red meat, decreased amount of alcohol. There was an interesting trial published earlier in the year. This was for colon cancer patients, but as they were on their treatment, this was a 3-year study where they did regular exercise, and they, on the study it showed that people who did regular exercise for 3 years, they actually had better survival compared to people who did not exercise. And then there was a study with breast cancer patients where they looked back and it showed there was 68% decrease in all-cause mortality if patient exercised on a regular basis and 37% decrease in risk of recurrence. So 150 minutes of exercise per week. And what should be the heart rate, Dr. Cripe?
Over 100, thank you.
All right, so we wanna start slowly. Your body has been through a lot. You have to give yourself some grace. Start slowly, set some achievable goals, listen to your body, be consistent, stay hydrated. And survivors experience a roller coaster of emotion. One day is good, one day is bad. There's so many things that play a role in their life. So 3 M's, mindful meditation, whatever you like. It could be exercise, journaling, it could be traveling. The next M is basically talking to a counselor. This significantly makes a difference once you talk to a counselor. And then lastly, we would talk about medications. Remember, a lot of people are hesitant on using medication, but take this as a temporary thing just to get over the hump. And I think Dr. Cripe already touched upon circulating tumor DNA, but I wanted to leave this piece because this is something upcoming for breast cancer patients. So these are tumor fragments that are detected in your blood, and it gives us a lot of information. So it can be used as screening, somebody who is developing cancer. It could be used to make treatment decisions, and somebody's done with treatment, then try and look for recurrences or more as a surveillance. So these are all breast cancer studies that are actually currently ongoing and looking at circulating tumor DNA. So for right now, it's not ready for prime time, but we are getting closer. So if the test is positive, does not give us any indication that if we intervene early, if it changes anything. And if the test is negative, that is not an indication that we need to stop treatment sooner. And I think my time is up. Thank you everyone for your patience and your time.
Next, we're going to go to radiation oncology. Dr. Vijay Kudithipudi, when radiation's complete, now what? Your follow-up roadmap. Interesting fact, I just found out, he likes going to famous restaurants. If he likes the dish, he tries to replicate it. And when he gets it perfect, he's actually had some of those chefs over and then gave them their own dish back. So that's great. I'm waiting for an invite to your house. Thank you.
Thank you all for coming today and your attention. All right, so briefly, we're just going to talk about how to get past radiation-associated fatigue. It's one of the biggest kind of negative impacts from radiation treatment, as many of you know. Skin issues in the immediate post-radiation period and kind of months to years later, and then skin and soft tissue changes long-term. So in the weeks post-treatment, as Shabana mentioned, just give yourself some grace. Radiation is often the last hurdle, kind of between the cancer treatment phase of life and getting beyond it. So it's a hard transition, and so mental and emotional recovery is as important, if not more important, than the physical recovery. At this point in the weeks post-treatment, most of my patients will tell me that fatigue, skin irritation, and breast discomfort are the three big hurdles from radiation to get past. Broadly speaking, fatigue should be getting better within a couple weeks out from treatment. There are three reasons I believe that radiation causes fatigue. I think the big driver is inflammation from treatment. And I think this is kind of proven in medical literature as well. They've done kind of blood samples in people after radiation and found all these inflammatory cytokines in blood. So it proves that there's something lingering in the blood after we're done with radiation. And so modulating inflammation is a big way to get past fatigue. Radiation does slightly lower blood counts and can cause something called mitochondrial dysfunction, which all that is, mitochondria are something in our cells that kind of help the cell run, create energy. And so that might be something that is adding to the inflammation and causing fatigue. So strategies to get past fatigue are successful when they target inflammation, essentially. So the number one thing I think that helps is stress management. So things like therapy, meditation, mindfulness practices, as we just heard about, can lower your stress levels, and that can indirectly support your immune health, getting past the radiation fatigue. It's been proven, as we just talked about, that exercise has the best evidence for relieving fatigue. And I agree with our other panelists that nutrition is incredibly important, especially plant-based foods such as green leafy vegetables and berries, things that have high levels of antioxidants. Minimizing excess sugar, processed foods, and alcohol can also help your recovery. And there's medical research that supplements, particularly American ginseng, 1,000 milligrams once or twice a day, can help support patients through radiation fatigue. There's less evidence, but suggestion that coenzyme Q10, so CoQ10, which is widely available, may also help. So skin changes is the other big thing. So during treatment, oftentimes physicians will have a very intense skin regimen. If any of you are my patients, you know that I'm very kind of restrictive about what I recommend. But moisturizers, particularly things like vitamin E oil, calendula, can support skin health. Prescription anti-inflammatory lotions, so think similar to cortisone, just a little bit stronger. Wound care products such as Sylvane can help inflame or open skin. And then common sense things like after radiation treatment, I recommend avoiding excess sun exposure, extreme heat, things like a sauna, hot tub, wearing loose-fitting clothing that's gentle on your skin, things like a cotton shirt, just to prevent friction from rubbing the skin, and using very gentle cleansers, things like Dove, can help in the weeks after treatment. In the months after treatment, most patients will notice that their skin is still dark, still a little bit thicker, but still tighter. Darkening of skin is oftentimes the most distressing thing in my patients in the months after treatment, because it keeps them from wearing the clothes that they want to wear, doing the things that they want to do, like going on vacation, going to the beach, things like that. It's a reminder of the treatment that you went through. It can take a year or longer for darkening of the skin to slowly fade, and there's very little medical research on things that you can do to help kind of get your skin back to your normal skin tone. Broadly speaking, I've seen, and anecdotally in my patients, that lotions that include things like retinoids, vitamin C, and vitamin E can help. And I've had a lot of patient success specifically with something called Palmer's Fade Cream. So I'm just putting that out there. It seems to be super helpful. Some dermatologists, including some of my friends, will do laser treatments for hyperpigmentation of skin. In the months out from treatment, I would hold off on it just because it can sometimes inflame the skin. And if it's already irritated from radiation, I would just give it time. So you know your body better than anyone else. When you feel like your breast is not inflamed or irritated, and if you're still experiencing darkening of the skin, it may be time to meet a dermatologist and talk about some treatments that they may be able to do. In the months to years out from treatment, again, you may still have darkened or thickened skin, but tightening is something that many patients will experience in the months to years out from treatment. And that's because of scar tissue forming, either in the skin, the breast tissue, or the muscle, or the connective tissue in between. And so generally speaking, I recommend gentle breast massage and referral to physical therapy if this is becoming an issue. Exercise is very important here because it can keep your blood vessels healthy. And if your blood vessels are healthy, that will help your body recover from radiation treatment. Not smoking is, I would say, job number 2. If you can do that, that will help. And you can consider vitamin E supplementation 1,000 units a day, with or without a medicine called Trental that has been shown to reduce radiation-associated fibrosis. In severe cases, something called hyperbaric oxygen can also be helpful. There are a few other tissues that can be affected by radiation. So the ribs occasionally can cause chest aching or something called costochondritis, which is painful. That, generally speaking, I recommend anti-inflammatory things like ibuprofen, Aleve. That's uncommon, but it can happen. Rarely, you can also get something called pneumonitis from radiation, and that is inflammation of the lung, which feels like a pneumonia, but it's because of radiation. So I always tell my patients, if you have a pneumonia and it's not getting better after antibiotics, and you've had radiation treatment, you need to call your radiation doctor because the treatment is essentially steroids. Again, rare, but it can happen. You can also get a feeling of food sticking, especially if you've had radiation to areas such as the lymph nodes underneath the collarbone. If that happens, it requires a referral to a GI doctor. And in these days, the heart, we work so hard to block the heart so that it is essentially receiving 0 radiation. But any number of heart conditions, there is an increased risk, both from some chemotherapies and radiation. So I would say just listen to yourself. If something feels off, reach out to your team. Thank you so much for your time.
We are going to have our speed dating with the experts next. So we've got a couple more experts that are up here. Dr. Santosh Kale is a partner of Dr. Saraswat, Dr. Corey, Dr. Kochek, also sponsors here. We've got Tyler Sbrocchi. Dr. Sbrocchi is a member of CAPS Group, also a sponsor. So we're going to ask a whole bunch of questions of everybody up here, and I get to choose what we ask. This is really fun. All right, Dr. Dewani, until you give us a dance, how do we know if tamoxifen is doing what it's supposed to do, and when does that outweigh the horrible joint pains, aches, and other problems of being on tamoxifen?
Oh my God. So, can you repeat the question? I zoomed into my Bollywood bus.
How do we know if tamoxifen is working?
Okay, all right. So, great question. We get this question often. After surgery is done, when we talk about chemo or tamoxifen, patient asks, how do we know it's working? Well, when a lot of what we practice is evidence-based medicine. So when patients get diagnosed with breast cancer, they have surgery, they randomize these patients to get tamoxifen versus no tamoxifen, and there was clearly a difference in risk of recurrence and in terms of how long they lived. If a lot of patients who are hormone positive, they get something called as Oncotype report, and that is a wonderful table where it actually tells you what is your benefit from anti-estrogen treatment. And if I had to generalize the statement, it decreases your risk by 50%. So if your risk of recurrence in next 10 years is 35%, or 36%, that brings it to 18%. So that's the benefit of tamoxifen. And the question, the second part of the question is, how does the joint pain ever go away? Good 25-30% people do experience joint pain with this medication. It all depends where you are in the spectrum, how bad your joint pains are, and what all can we do to help you tolerate that joint pain so you can take your tamoxifen. Sometimes we have done dose modifications, sometimes we have given you a treatment break, sometimes we look into some alternative options in terms of what we can do other than tamoxifen to help decrease the joint pain.
Thank you, Dr. Dewani. All right, we've got one for the plastic surgeons. We've got a whole panel, so maybe we can take a vote. That's a good question to say, what's the safest method of breast reconstruction? Implants or using your own tissue? What's the safest and what's recommended? We just go down the line. We can start with Shabana. Safest and what do you recommend?
Yeah, I think different types of reconstruction are in a lot of ways equally safe. I think it's more about your patient's background, what comorbidities they have, if they've had radiation in the past. I think those factors more likely lead us down the path of one type of reconstruction than the other. I think a lot of the types of reconstruction are safe. When we do tissue-based reconstruction, it's certainly more hours in the operating room, but we wouldn't really offer it if it's not something that's well tolerated, and that in some ways kind of prevents future surgeries down the line. So I would say they're equivalently safe. I think it's more about the patient than the reconstructive option.
Any of the plastic surgeons disagree?
I was going to say ditto myself. I completely agree. I'm a little biased because I only do implant-based, so I have that perspective to offer, but did free tissue transfers and training, and just like Dr. Saraswat said, I think it's patient-by-patient basis, certainly comorbidities, and then what the patient's goals are too. Are they looking for a faster surgery, if you will, or are they really against implants versus tissue-based? So all of those factors play a role too, and then what they're looking to get out of their surgery. So all of those things you'll talk to us, all about in the consultation, and then hopefully we can get you, your best result possible and meet all those goals that you have, for surgery after.
I'll say first, it's not fair to be last.
Start first next time.
I don't have a lot to add to that other than it's all about the pros and the cons. And when I meet with my patients, we just sort of list what are the pros of implant-based reconstruction, what are the cons of implant-based reconstruction. Second, with Dr. Sbrocchi and Dr. Saraswat said, which each patient is very different. But at the end of the day, they're both very safe. And at the end of the day, it's really tailored based on what each patient needs.
Since you have a mic, what is a rib-sparing deep?
Oh yes, I love rib sparing deep. So when we're doing the deep flap, we're transferring the tissue from the belly, or really the thighs, buttock, lower back, to the breast. So as we transfer the tissue, we can't just take the tissue off and just put it in the chest and call it a day. So we have to disconnect the tissue from its blood supply, and we have to reattach it to new blood vessels in the chest. So those blood vessels that we use, those are the internal mammary vessels, and they run underneath our rib cage. So in some instances, we have to remove a small segment of the cartilaginous portion of the rib in order to identify the internal mammary arteries and veins so that we can reconnect it. Now, as we have become more experienced, we're able to go in between the ribs without having to remove the cartilage. And to a point that Dr. Saraswat said, we're doing these big surgeries, but at the same time, we're trying to minimize the areas that we touch. And so in a rib-sparing deep flap, we're leaving the ribs in continuity, and we're doing the work in between the ribs.
That was very good, technical. What is radiation fibrosis, and what can we do for it?
So generally speaking, I think of it as scar tissue. the way I think about radiation is the goal of it is to kill the cancer by turning it into scar tissue, but there's a lot of the rest of your body in the way, and unfortunately, that can lead to scar tissue. I think the best thing to do about it, as I was saying earlier, is to do things which improve your overall cardiovascular health. So things like a primarily plant-based diet, exercise, and I'm considering vitamin E supplementation. If those things are not helping, then I will refer to physical therapy for rehabilitation. They have any number of techniques that they can use to help break up the scar tissue, and if that doesn't work, we rely on our surgeons, plastic surgeons, breast surgeons, to help out.
Thank you. I'll take one. What's the typical follow-up after preventive or called prophylactic mastectomy? So someone's at high risk, we remove the breast tissue with or without reconstruction. The follow-up is the same as kind of after you've had a mastectomy. No imaging, no mammograms, no MRIs, just a physical examination across the pond. So we have in Europe, they said that they recommend a once-a-year clinical exam, and then monthly just knowing your body and looking for any changes. So even if you've never had cancer and you've had your breast removed, we still recommend once-a-year clinical breast exam. So a good question, thank you. Let's move on here. What if you had triple negative breast cancer and you have menopausal symptoms? Can you take hormones, Dr. Dewani?
So it depends where you are, how long or how far out you are from your treatment. The answer is not yes or no, but yes, it could be an option. And always it's a risk-benefit discussion. If your life is miserable and you're 10 years out from your TNBC, I would say yes. But you just finished your treatment like a year ago and you have minimal symptoms, then my answer would be no.
And a lot of this is, it depends. I think that's what we're going to say lots of times. What if, going back to implants, what if you're a survivor and you've had implants under the muscle? When do you know it's time to change? Maybe the implants need to be changed out. Should you go on top of the muscle? Are there other recommendations? What do you guys recommend? Start in the middle. Can you go, Dr. Collins?
It depends. So there's no wrong answer in breast reconstruction. It's all about the patient. And when we talk to you guys in our consultation about pros, cons, like Dr. Kali said earlier too, there are pros and cons to above and below. So sometimes patients below the muscle, you can have an animation deformity where if you move your chest or your pec muscles, it will shift the implants a little bit. And so if that is causing pain or discomfort, or there's some scar tissue or tethering that's building up, and over time it's kind of affecting your daily life, like we've talked about, some of these symptoms that is sometimes a time for discussion of, is this something that is bothering me every day, something that can be fixed as well? And that answer is yes. Yeah, you can change that plane of where the implant is. And sometimes if you're having a lot of those symptoms, that can be mitigated by switching the implant to above the muscle, and vice versa. And you can go below the muscle too if you're above, depending on those symptoms. So.
Dr. Collins?
Yeah, so I second that. So if it bothers you, then we can do something about it. If it doesn't bother you, and just say the implant, which for most, it has a lifespan of about 10 years, when we have to change them out, if it doesn't bother you, we can just keep them below the muscle. But just the one thing I would say is when we do transfer it from below the muscle to above the muscle, it is a little bit more involved, that surgery.
Yeah, I just want to go first next time, but I don't have a lot more to add to that. The only thing I would say is, I have kind of a similar conversation with anyone who comes into my office after having implants in for so long, and there's no expiration date on these permanent implants, but like Dr. Colley said, we like to get them out and switch them out after every decade or so, just because there may be an increased risk of rupture, capsular contracture, what have you, but I agree with everything that was said.
You know the joke that if you see 3 plastic surgeons, you get 4 answers, right? Couple questions here. Keep looking at what supplements, what foods can we take if we have hormone-fed tumor? Are there good supplements that we should be taking? Are there foods or additives that we should avoid in our foods that could be hormone-related? Dr. Dewani?
I am the first and the last and the middle.
We have it right here, folks.
So as far as supplements, typically I tell patients to take vitamin D3, especially in Ohio. A lot of us are deficient in it. And that does make difference in, especially if you have joint aches and pains, in how you're feeling. As far as food, we definitely recommend lots of fruits, vegetables, a lot of color in your food. Please avoid processed food, decrease the amount of red meat consumption, limit the amount of alcohol. And as far as additional supplement, can you take a multivitamin? Yes. There are so many other supplements out there, like turkey tail, mushroom. We usually, when you're on treatment, and nowadays we put a lot of patients on targeted treatments, even in adjuvant setting like CDK4 inhibitors, we try to avoid all those supplements other than just a multivitamin, a D3 and a B12, because we just don't have data how that's going to interfere with those medications. Will it increase the toxicity, or whether it will interfere with the efficacy of the treatment?
Great, thank you. And there's a lot of stuff out there, keeps changing. And there's also a lot of advice, a lot of stuff on the internet. It's hard to know what you're supposed to do, but that is a challenge. There are a lot of great questions you guys have, so thank you so much. One of my favorites here is, we know we're supposed to stay away from alcohol, we're supposed to stay away from smoking. There's a lot of bad things that can be out there. But if we're on vacation, Dr. Dewani, can we just go have a couple drinks? Don't everybody get up and run over there. Right?
Depends.
What are current guidelines for patients that have implants, and looking at that cancer associated with some textured implants that we don't use any longer? Do we have guidelines on what people are supposed to do for that? You go first.
Sure. So I think it depends on what kind of implants were used in the past. The smooth implants that we use today and the nanotextured implants that we use today, there's really, and correct me if I'm wrong, there's no incidence of those being associated with breast implant-associated ALCL, which is kind of the worry with older implants that use salt elution and other techniques to kind of create that texture. So all of the implants that we use today are safe. There is a small risk, and that risk, depending on the type of implant, can be 1 in 8,000 to 1 in 30,000 of getting this ALCL. But again, with smooth implants, it's never been seen. With nanotextured implants, it hasn't been seen either.
Yeah, I'm glad you went first on that one. No, I completely agree with Dr. Saraswat. This old ALCL, or the breast implant-associated cancer that you may read about or see, certainly if you research implants, and it was associated with this old textured implant that's obviously since been pulled off the market, and that's why now we don't use those anymore. And Dr. Saraswat's right, I don't think I've ever read about a case report or anything that if there was an association with a smooth implant, they probably had this old textured one and swapped it out and then developed it secondarily. And like you said, I think depending on what you read, our literature is all over the place. It can be 1 in 80,000, so it's extremely rare. We've all, I think, probably worked up some patients for it at some point. And so there is, short answer is yes, you can work patients up for it and find it. And there is treatment for it, but it is extremely rare. So these new implants, I almost never even worry about it because the smooth ones have not been associated, and that's primarily why we use those now, amongst other reasons. But
I agree.
All right, I think our time is up. We're going to change out to another panel, but thank you all so much for your expertise. Changing, and our next group of presenters are coming up. There's a number of these questions, really, really good questions. We couldn't get to all of them. Dr. Hall-Harvey's going to put it on the Breast Cancer podcast, so she's going to have some of these questions listed. So if you didn't get your question, we're going to have it on the podcast later. So.
Yes, I want to say thank you to all our sponsors, and they are CAPS, Dr. Sbrocchi, thank you. Midwest Glowlux Med Spa. Over my head. PRG. Ohio Health. Dr. Arthur G.H. Bing. Apex Urology and Aesthetics. You're all wonderful. Give it up for panel 1.
Thank you, everyone, for tuning into the Breast Cancer Podcast. Remember, you're not alone in this fight. I encourage you to be an active part of this podcast. Please share your stories, questions, and suggestions for future topics at my website called drdeepahalaharvi.com. And please share this podcast with others, especially if you found it useful. And please also give it a 5-star rating, if you will. Stay connected as we navigate the complexities of breast cancer. Until next time, take care and keep shining brightly. Disclaimer, this podcast is not intended for complete medical advice, so please talk to your medical professionals.